Hello, everybody. My name is Andrew, and this is my presentation of a study design aimed at understanding how tuberculosis related stigma impacts patient adherence to treatment. I hope you find it both informative and enjoyable. Tuberculosis, or TB, is a chronic infectious disease commonly caused by Mycobacterium tuberculosis. TB typically affects the lungs and is easily transmitted through droplets projected into the air from speaking or coughing. Although a treatable disease, TB can rapidly become resistant to traditional forms of treatment and can ultimately become fatal to the host when treatment is disrupted. The stigma associated with TB is considered a common culprit that prevents infected individuals from receiving and adhering to treatment regimens, contributing to the disproportionate burden on these patients who could otherwise avoid adverse health outcomes. These stigmas are often related to social determinants of health connected to TB. This public health predicament serves as an area for in-depth study to understand how exactly these stigmas influence treatment trends and provides a need and an opportunity for targeted interventions to minimize stigmas and increase TB treatment rates. That being said, the question I am interested in exploring is, how does stigma associated with TB affect patient outcomes and treatment adherence? This presentation aims to propose a mixed method study design and methodology aimed at gathering patient information about the stigmas associated with TB and discuss the projected outcomes of implementing this type of research campaign. According to the World Health Organization, approximately 10.6 million cases of tuberculosis were reported in 2022, resulting in about 1.3 million deaths among those who were infected. This statistic places TB as the second leading cause of death from infectious diseases and the 13th leading cause of all deaths globally. Mycobacterium tuberculosis is a highly contagious bacterial agent that can infect individuals of all ages worldwide. This is especially hazardous for patients who have suppressed or compromised immune systems, such as those living with severe malnutrition or an active HIV infection, during which dormant TB is more likely to transition into an active disease. In most cases, TB is treatable with uninterrupted antibiotic regimens for about 4 to 6 months. However, the high adaptability of Mycobacterium tuberculosis contributes to a more significant public health problem of becoming drug resistant if treatment tapers off. As of 2021, the World Health Organization reported global TB treatment coverage at 61%, which is down from 69% in 2019. However, coverage remains below 50% in countries with a high burden of TB, such as Myanmar, Lesotho, and Mongolia. The stigmas associated with TB are often connected to impoverished regions with poor sanitation, where malnutrition and lower socioeconomic status are more common within communities. This reality only perpetuates fear of marginalization and reluctance to receive and commit to the necessary treatment protocols needed to quell TB disease and prevent further spread. This makes it imperative to understand the TB stigmas within these demographics and work to reduce their harmful influence to encourage increased rates of treatment. A mixed method study design would be the most appropriate approach to understanding how stigma associated with tuberculosis impacts treatment adherence and patient outcomes. Mixed method studies combine quantitative and qualitative research tactics to provide a more comprehensive understanding of the issue being examined. The quantitative component will consist of a cross-sectional survey to assess the extent of stigma, treatment adherence, and health outcomes among TB patients, and subsequent statistical analysis of relationships between stigma and receiving treatment. The qualitative component will consist of interviews with TB patients regarding perceptions of experienced stigmas and their impact on health-seeking behaviors, followed by an analysis of the recurring themes among TB patients. The resulting data from both research methods will be reviewed for overlapping trends and used to project reasonable outcomes. Since this study aims to utilize human participants, it will require approval by the International Review Board. All participants will also receive consent forms to inform them of the intent and the nature of the study and ensure that all information provided will remain private and confidential and will be limited to the purposes of this study. For this research question, volunteer TB patients who have halted or avoided treatment would be the primary data source. TB patients who have transitioned into multi-drug resistant TB or have otherwise completed their recommended treatment regimen will be excluded from participating in this study. A minimum sample size will consist of 100 patients randomly split into two groups to minimize selection bias, 50 for the quantitative and 50 for the qualitative research components respectively. To minimize bias during later analysis, TB patients placed into the qualitative research group will be interviewed individually to avoid any influence from other patient responses. Details about the surveys, interviews, and their respective analyses will be further elaborated under the upcoming methodology. A cross-sectional questionnaire will be prepared for the first randomized group of 50 participants. This questionnaire intends to gather information on patient demographics, including age, sex, marital status, income range, and education level. This survey will also include questions that intend to gauge different aspects of patients' mental health, including fear, depression, and anxiety levels, the level of their perceived intensity of tuberculosis stigmas, the level of their adherence to TB medication, and the level of severity they would rate their symptoms of TB disease. Patients will be asked to rate responses on a scale of 1 through 10 for their personal experiences and perceptions. Using SPSS software, patient responses will be statistically analyzed through correlation testing to gauge potential relationships on two fronts. The first analysis will test for a relationship between perceived stigma intensity and treatment adherence, and the second will test for a relationship between perceived stigma intensity and disease severity rating. Qualified research professionals will conduct interviews with the second randomized group of 50 participants. The interview questions are designed to add context to patient experiences within their respective communities and assess how stigma plays a role in their perceived ability to receive and adhere to TB treatment. Questions that will be asked during the interviews will include the following. 1. Do you feel a sense of fear of being isolated because of your TB diagnosis? 2. Do you feel it necessary to keep your TB diagnosis a secret from your family, friends, or coworkers? 3. How do you think people in your community view TB and those who have a formal diagnosis? 4. Can you describe any personal experiences where you felt judged or treated differently because of your TB diagnosis? 5. How does your fear of stigmatization impact your ability to stick to your treatment instructions? 6. Did you experience any feeling of hesitancy in seeking medical care for your symptoms before and after your diagnosis? 7. Do you feel that you have enough support from family, friends, or the healthcare resources in your community to begin or continue with treatment? 8. Do you experience depression or anxiety due to the way others perceive you because of your TB diagnosis? 9. Do you feel judged or mistreated by healthcare workers that know you have a TB diagnosis? 10. What advice would you give to other patients about dealing with stigma related to TB? Using Deduce software, simplified codes will be created to categorize the most common themes expressed during interviews. Participant responses will be assigned an appropriate code and thematically analyzed with a code cloud model. From the quantitative perspective, similar studies have found that tuberculosis-related stigma is usually perceived but is moderate amongst those who are receiving treatment, yet it is still expressed as a reason for wavering on treatment. They also demonstrate that relationships between these factors exist but are typically moderate in strength. Assuming that perceived TB-related stigma is high while treatment adherence is low, however, this relationship could potentially be stronger within a different sample. Based on the likelihood of TB progressing without treatment, it can be inferred that patient ranking of severity would also be high in this scenario due to more aggressive symptoms. Following the appropriate statistical analysis for the variables in question, it is expected to see a relationship between the strength of experienced TB stigma and treatment adherence. The same can be expected for establishing a relationship between stigma and the perceived severity of TB disease. The resulting outcomes would entirely depend on the responses received during participant data collection. On the qualitative side, Based on the results of the interviews, it is expected to see common themes of fear, depression, anxiety, isolation, and hesitancy to disclose information to others. The stigmas associated with TB likely act as barriers to seeking and continuing with treatment. Related studies have demonstrated that TB patients tend to show reluctance to convey their diagnosis to family or community members for fear of being isolated. The onset of depression and anxiety are cited as contributing factors to wanting to avoid treatment, while enhanced community support would help patients feel more open to treatment. With these findings in mind, it can be inferred that stigmas play a role in the emotional and social elements that prevent patients from adhering to TB treatment, and that additional support and resources would increase the likelihood of receiving medical care. Tuberculosis continues to pose a significant public health issue due to its disproportionate impact on vulnerable communities worldwide. The stigma associated with TB infection presents a critical roadblock in ensuring affected individuals receive the treatment that they need. It is therefore imperative to promote ongoing efforts to discuss and address the global disparities in vulnerable communities and the stigmas that often go with them. In pursuit of a better understanding of this phenomenon, the mixed method study design described above can provide additional context between the relationship between TB stigma and patient outcomes. By establishing and validating this correlation, further research efforts, including future testing of other variables gathered during data collection, are promising leads. With this expanded knowledge base, targeted public health interventions can be put forward to minimize these stigmas and encourage increased rates of TB treatment, guiding experts on a more streamlined path to eradicating this disease. Thank you all for taking the time to tune into my presentation on tuberculosis stigma and its effect on treatment adherence. Here are the references used throughout this video. Have a good evening.